Thank you for joining us today. My name is Shoshana Six. I'm a proud member of the Bowdoin class of 2004, and I'm joined today with several members of our class. Before we begin, I just want to mention that there is closed captioning available, and also the Q&A box is available should you wish to pose any questions to our panelists. I want to introduce Kristen Pollock, who is co-moderating with me today. Kristen is the national chair of the Bravo Admissions Committee, so some of you may know her through that work. And again, I'm Shoshana Six, and I'm the incoming chair of the Alumni Fund Directors. So more importantly, we want to get to our panelists, several members of the class of 2004, who are all working on the front lines of the COVID-19 pandemic. And I'm going to start with them, allow them to introduce themselves because they can tell their stories better than I can. So, I have one very important thing I'd like to say before we get to them, which is just that these opinions of the panel are all their own. They do not in any way represent Nemours AI DuPont Children's Hospital, the Philadelphia Department of Public Health, Tuba City Regional Healthcare Corporation, or Navajo Nation. So I'm going to start with our panelists, and Jack, we can start with you. If you just all will introduce yourselves, you know, your name, your profession, you know, what you do professionally, and then if you have any brief words about how Bowdoin influenced your path to where you are now.
Sure, thanks, Shoshana, and thanks for this opportunity to be part of this panel. I'm really looking forward to it. I'm Jeff Hom, and I'm an internist and medical director in the Philadelphia Department of Public Health. And my role during our city's sort of COVID response has been on healthcare surge planning and the opening of a COVID surge hospital. And I would just sort of say that, you know, Bowdoin, I think, very much inspired me to pursue this work. Not literally, perhaps. I mean, I don't think any of us in Brunswick in 2004 would have expected responding to a global pandemic. But the college certainly, you know, deepened within me the value of service and being of use.
Shanique?
Hi, good afternoon, guys. Shanique Kilgallon, formerly Shanique Brown here. I am a pediatric anesthesiologist, currently at a 100% pediatric hospital. My role during this very unique time that we're experiencing is on the front line as someone who manages airways and oftentimes has to resuscitate patients who are afflicted with COVID-19. So in terms of how the college has impacted my experience, what comes to mind is the common good. You know, a lot of people say, you know, frontline heroes, and I think that terminology is a bit problematic at times because in the end, it's all about the common good and doing what you are expected to do and should do in order to keep yourself and everyone else safe around you.
Jared?
Yeah, hi everybody. I'm really excited also about joining the panel today. So I'm Jared McAteer. I'm an internal medicine doctor by training, and I work at Tuba City Regional Healthcare Corporation, which is one of the hospitals that serves the Navajo Reservation here in northern Arizona. So I came here via working at CDC for 2 years, actually training to be an applied epidemiology outbreak responder. And to be honest, did not think that I was going to need that skill set coming to Tuba City. And boy, was I wrong. And so I think exactly what Jeff and Shanique said, I think that Bowdoin has really instilled a sense of social conscience in me. I think that's what got me to want to do the work at CDC and really what brought me here.
Amanda?
Hi, I'm Amanda Burrage. I am a pediatrician by training. I also came to Tuba City Regional Healthcare Corporation via the CDC and was there for the 2-year EIS, or Epidemic Intelligence Service Fellowship, where we learned how to do disease outbreak investigations. We had wanted to come to Navajo Nation because the medicine is really interesting, but there's also sort of inherent public health needs, but also did not predict a pandemic. So that has been exciting. In terms of Bowdoin, so I think, you know, some of the things about Bowdoin is that it encouraged us to sort of try a bunch of different things. I think I took a class in almost every department. And so I think being able to sort of combine things and explore, and I was not pre-med until the end of Bowdoin. And so I did not anticipate this pathway, but I feel like all the different influences from the different departments sort of helped put everything together.
Great. So we'll start, we have a couple, as our audience may have gleaned already, a couple clinicians who are working with patients infected with COVID-19. We also have some, although you're all physicians, some who are working more in the public health response. So we're gonna start there, and I'm wondering, this is for Jeff and for Amanda, who's helping to coordinate the response into the city. If you can sort of talk about the key features and structure of your public health response to the pandemic.
Sure, I can start. So my view is from the city's health department. Philadelphia is a city of 1.5 million residents, and we have experienced really, I think, the tremendous challenge of COVID-19 in a dense urban setting. So in fact, Philly had actually the highest death rate of any city during the 1918 influenza pandemic. And that history is not something that's lost on us in the health department today as we work to mitigate the spread of the coronavirus. So as of today, we have nearly 25,000 cases of COVID among Philadelphia residents and just over 1,500 deaths. And so early in the year, our health department was essentially restructured to focus solely on COVID, in which every staff member was reassigned to focus on some aspect of the response. And our response has included operations focused on surveillance and epidemiology, testing, PPE procurement, isolation and quarantine, outbreaks, particularly in nursing homes, public guidance and education, and then healthcare surge, which is sort of where I've been working.
Can you give a little more detail on the surge aspect?
Sure. So, so pre-COVID, my job was as the medical director of the Division of Substance Use, when I was really sort of focused on addressing drug overdoses. But then during COVID, my role has really sort of changed significantly. And as I mentioned, I sort of helped oversee the development of the city's surge hospital, the purpose of which was to help care for patients with COVID in case the hospitals in the city ran out of beds. None of us wanted to need a surge hospital, but we had seen what had happened in neighboring New York City and overseas in Italy. And we knew that not preparing and having no place to care for patients really could be tragic. So over the course of 2 weeks, we transformed the basketball arena at Temple University into a surge hospital. And in late April, the hospitalizations in the city peaked at just over 1,000 inpatients and did necessitate the use of the surge hospital for a brief period of time. And so I would just say, I think from my perspective, I'm relieved that it's no longer needed. We currently have fewer than 250 inpatients with COVID in the city's hospitals. And then opening it was such a huge challenge, but one that I was glad to be a part of. I think we learned so much from the process, and should we need to open one again in the future, hopefully not, I think we'll be able to do it better.
Amanda, can you talk a little bit about how that differs from the response you've been helping to coordinate in Navajo Nation?
Sure. So first I'll set the stage a little bit. So Navajo Nation, there are 300,000 people registered in with Navajo. There are 180,000 on the reservation. The reservation is the size of many states combined. So New Hampshire, Massachusetts, Connecticut, New Jersey, Rhode Island, and Delaware. It's the size of West Virginia, so it is very large. Our service unit, so our hospital covers 34,000 patients or so. So that's like the size of Brunswick and a half or so. So, and that is spread out very wide. So there's, people are very spread out across a sort of vast landscape. On Navajo Nation in general, there are 38% of people that don't have running water, about 30% without electricity. There's limited cell phone access and internet access, and there's a food desert throughout. There's only 13 grocery stores in the whole area, which is, I mentioned, all those states' size. So there are a lot of challenges in general. In terms of our public health response, so Navajo Nation is not covered by the state health departments. So we are in Coconino County, but the county does not do any work for us. So we are a small rural community hospital, and we sort of had to jump in and pick up all the things that Jeff mentioned, but for ourselves, essentially. So I think it's been helpful that Jared and I are here sort of with the CDC experience, but are by no means experts in all the things that Jeff mentioned in terms of like the surveillance and epidemiology, the PPE, how do we get PPE, what are the infection prevention measures for the hospital, contact tracing, all the sort of public health outreach, the education, the community education, and all of that is unique to our population in many ways, just because it is a very unique population in terms of the individuals and the families, in terms of the living situation, also in terms of geographically how spread out they are. So we have had in our hospital over just about 800 cases. We've had 300, so 40 of them 40% have been hospitalized, and we've had about an 8% death rate so far. So we have been hit very, very hard. Our hospital, our first case was on March 18th, and our hospital was full essentially from that week until thankfully 2 weeks ago. We are no longer 100% full, but it has been a very intense and prolonged pandemic in terms of our area, and it is definitely still present.
So I'm going to transition just to you, Jared, and Shanique afterwards, asking you about your experience providing clinical care to COVID-19 patients and how it's different than your traditional work providing care.
Yeah, so I guess before the pandemic started, I was a primary care doctor here in Tuba City, and then also one of the hospitalists. So we have, so sort of doing two roles. Our hospital is, as sort of Amanda mentioned, we are a rural hospital. We have limited capacity. We have an inpatient ward. We do have an ICU that is staffed by us hospitalists. And, we were taking care of maybe, I don't know, maybe 30, 40 patients at a time. And as Amanda said, in early or mid-March, we had our first cases that came through the emergency room who were critically ill, requiring oxygen, needed to be hospitalized. And within 24 hours, 48 hours, we had to turn our little hospital into a hospital capable of handling really sick, critically ill patients. And that took like this momentous shift in the way that we triage patients, the way that our hospital staff is allocated, the way that the rest of the hospital staff were being used and utilized. And so for me, being one of the internal medicine doctors, and maybe fortunately, most of the cases that we've seen with requiring hospitalization and coming to sort of the surface of COVID-19 have been adults. I think in the beginning, I think just like anywhere else in the country, I think people were really scared. People were unprepared. We didn't know how to best keep ourselves and our patients safe, how to keep our community workers safe. And I think that sort of relying on everybody's skill set here, we came up with a really good system of triaging patients appropriately, treating them quickly and promptly in the emergency room. And then when they get to me on the medicine ward or in the intensive care unit, really coming up with a strategy of how to deliver, really high quality evidence-based care when we can, and do that over and over and over again at a capacity that we were never used to seeing before. So our hospital had to create a respiratory care ward, which didn't exist previously and was one of our pediatric wards that we had to transition into the respiratory ward. And we had to bring in extra nurses. We repurposed our nurse practitioners to help us with the nursing capacity, who truly are the people that are providing the best care for these patients. And we were able to start caring for, at first, 10, 12, 20, 25 patients, basically, in our hospital, which is a huge increase from the numbers that we were initially seeing. And so, as someone who's taking care of patients with COVID-19, we see the spectrum of disease. We see people who come in and are needing some oxygen therapy and some supportive care, and we are seeing people, unfortunately, who need really who are critically ill and need intensive level care. And so we've had to do all of that with sort of the limitations that our little hospital has, and sort of the limitations of the health system itself. What does it feel like to be on the COVID? This is the question that a lot of people ask, what does it feel like to be on the COVID ward, taking care of patients? People are really sick. Are you worried about yourself and getting sick and bringing it home to family and things? Absolutely at first. And now it's become, I feel like we're doing a really good job. I feel like we're understanding the disease better. And so it feels like this is why I got into medicine, right? I want to be caring for the patients in my community. I want to be caring for people who need my help. And so I find the work long hours, but really fulfilling. And sort of that initial sort of unknown has given way to really like a lot of gratitude of taking care of these patients, hearing their stories that we can talk about a little bit later about like who are the patients that we're seeing on the wards, but feeling really grateful that I get to do this every day, and working with my colleagues here and working with an incredible number of people who are doing jobs that they weren't trained for. So we have and dental staff working in.
I think we lost Jared momentarily.
Yeah, it's been really wonderful.
Got you back? No, we cut out for just 1 second.
Oh,
so.
Okay. Sorry, I have a predilection to talking too long, so I'll stop. Maybe I'll pause.
That was the sign.
Yeah, that was the sign. Technology telling me to pass the baton.
I will go over to Shanique then and ask you the same question. Just what has your experience been treating patients with COVID?
So a lot of times, so I'm a pediatric anesthesiologist who also is trained in adult anesthesia. And I've recently come back to 100% peds, but just prior to this, when COVID was starting, I was in the busiest level 1 trauma center in the state of Pennsylvania. And some have quoted it to be the 4th busiest in the state. And so this is a place that's incredibly well equipped, generally speaking, for what you expect from day to day, and really are used to very urgent things happening quickly and people being able to respond quickly. And so as a person on the front lines, one of the first things that I was thinking about before the mid-March, because I was watching the news in China, or the news coming out of China, was that this is coming. And so before the mandatory, you have to wear a glove, have to wear a mask 24/7, you have to wear goggles, I had started doing that before it became mandate. And I remember one of my nurse anesthetists who was looking at me, and she said, "Look at you in your getup." And I was like, well, I've got 2 kids who are high risk, and it's coming. And so for me, thinking about PPE and how I use it from day to day, and how just in that moment, a week later, we're all dressed up like that. And yet we still have to be very conscious with how we use it, because typically it's, you use one mask, you discard it after each patient interaction, and now you have to think, we are in the middle of a surge, things are going to be changing, how can we reuse what we have in a safe manner that's not going to put others at risk, which is very kind of counterintuitive to what you've thought about from year to year, particularly when JCAHO comes and evaluates your hospital, evaluates your program, all of a sudden I'm allowed to reuse a mask. It's very kind of uncomfortable when you've been told that's not what you do. And so part of understanding the pandemic is understanding how so much is in flux, right? So when you have an education, you read books, when you read articles, a lot of things are based on someone's research or a group of people about why you may differ in an opinion about something. You can say, well, the research suggests that maybe I should be wearing 2 masks or double gloves or a PAPR or whatever it is, but I don't have that detail. We don't have that detail yet, because it's happening right now in a very dynamic way in terms of everyone figuring that out. And so, with what we have, our professional organizations have put out various recommendations about how we should be effectively dealing with patients with COVID. First, all the elective cases stopped, right? Which meant a lot of hospital revenue stopped, which meant doctors who are on the front line then become furloughed, which is a very interesting thing to deal with. And yet, when you are there, you have to be thinking, is this what's being recommended as the best case? And it's not, you're not always put in a situation where it is, where you have a trauma patient coming in. If everyone's saying we don't want to do certain invasive airway procedures in order to protect the space, sometimes you don't have the time to really get all of the things in line in order to make sure you, your patient, and everyone else in the room is safe. And so I think what I've appreciated is, now that we've moved out of March and now we're into June, is that we've created better systems in how to deal with those situations. It's one thing when you know something is coming, when you know the patient is booked for the 12 o'clock appointment and they have these symptoms that you're going to be high alert for, versus the guy who gets hit by a car who has double pneumothoraces and are coming in and need an airway management now. And by the way, he's got all these other things wrong with him. So it started, you know, that kind of uncertainty with the information out there in terms of what to be done, what needed to be done at any given point, particularly in the beginning, was quite unsettling for me as a chronic rule follower in some ways, and really wanting to do the right thing. And because not only would the right thing impact my patient, but it would directly impact me, where I have my oldest son who was just hospitalized for an asthma flare, you know, a month before all of this started to happen. And God forbid, if I'm not protected properly and I come home and I bring it home, I now have to deal with that self kind of disappointment that I brought that home, you know, even though it could be picked up from anywhere. So I think in terms of dealing with the frontline aspect, if we, as an anesthesiologist, as an intensivist, I'm not an intensivist, but I'm an anesthesiologist, you are literally face to face. I am 4 inches from someone's face when I put a breathing tube in sometimes. And that is something that is incredibly impactful. It impacts your life in a way that I had never really appreciated it for, because I'm facing something I can't see, but that will completely, because on a personal side, I have family members who've had COVID. A lot of my family in New York, where the healthiest of one of my cousins who runs marathons and is vegan and all those things ends up in the ICU. But my aunt with stage 4 breast cancer does not. And you know, it's all the things we think about that protect you aren't all the things that kind of make sense right now.
Mm-hmm.
I just want to interject quickly and let you guys know that you guys can enter in questions, those of you who have joined us, through the Q&A feature, and we're going to try to answer those throughout. So just wanted to make a quick note. I think we've gotten a couple so far. But.
So related to that, Jared, you had mentioned patient stories, and there was a question in the Q&A related to patient presentation also. That Kristen will throw in, but I did want to give you an opportunity if there's a particular story that you wanted to tell of something you've experienced to do that now.
Yeah, sure. I was sort of thinking about how to sort of paint the picture of what sort of the struggles that we have here. So I was just last week, I was working in the ICU in our respiratory ward. So we had, this is the common story. So we have a patient who has chronic comorbidities. We know that the patients here on Navajo Nation have higher rates of chronic kidney disease, higher rates of coronary artery disease, higher rates of diabetes. And so this person was one of those people. He's an 80-year-old guy. He had chronic kidney disease, diabetes. He had some lung disease that was sort of suspected. Maybe it was from sort of the uranium exposure that a lot of people have had out here. And so was on oxygen at home. And, he was telling me that, he was doing everything right at home. He was wearing a mask every time he went out. He was washing his hands. He was trying to social distance. But he was saying that it's really hard to do that here. So one of the challenges that we faced here is that people on Navajo live in multi-generational homes, meaning that there are many generations under one roof, where sometimes people can live 6, 7, 8, 10 people in a home. And so if one person gets sick, you can imagine that it's really, really difficult to isolate yourself, to socially distance yourself from that community members. And people live with their elders, 80, 90-year-old grandparents, and those people are really, really at high risk. And so he lived in a family of about 6 or 7 other people, and his brother got sick. He did everything right. They tried to isolate him in a room in the house, and then his wife got sick, and he continued to isolate himself, and was relying on family members. He put a sign outside his door outside the house saying, "Please don't come in. Please stay away. I'm at high risk." And despite that, he had family members that would come in because he was one of the only family members in the area, and he was the patriarch, and he had water and electricity. So people wanted to come to his house for water, electricity, watch TV. And unfortunately, 3 or 4 days before I got to meet him, he came into the hospital. He was more short of breath. He needed oxygen, and was admitted directly to our intensive care unit. And, it just shows you that this disease sort of lays bare sort of the underlying struggles that I think that we all feel, whether it's in Philadelphia, whether it's on Navajo Nation, that the social determinants of health really become omnipresent, I guess, when people show up to the hospital. And this gentleman, unfortunately, he got sicker and sicker. And unfortunately, we ended up having to put a breathing tube down his throat, help him breathe, put him on a ventilator, and send him to one of the bigger ICU hospitals in the Phoenix area, where he could receive really what we think is the treatment that he deserves. I don't think that we were able to, in Little Tuba City, to be able to give him the advanced ICU therapy that he really deserves and needs. And I think that this story is really common, right? These are the struggles I think that we feel from a public health perspective, from a clinical perspective, and once the COVID crisis and pandemic starts to wind down, we're still going to be left with all of the social determinants of health that make our patient population really vulnerable.
Did anyone else want to jump in, Jeff, Amanda, with Shanique, with other stories?
I think one of the, this whole thing, right, has made us realize that at least myself, that this job can be very dangerous, right? When you're a police officer, it can be dangerous. When you're a firefighter, it can be dangerous. When you're in medical school, you never think that you could be in danger. And what would move me the most in a way towards fear in some ways, I know New York Times wrote an article about doctors are now writing their wills, is when I have to take care of a patient who's an anesthesiologist, get consent from the wife who's in tears, who's a physician, and hear about the gentleman who's an EMT or a heliport guy who's dead. That is not something physicians, I think, and people in healthcare have experienced before, where all of a sudden the people who you work with from day to day, or who could be you, are in such a critical state, and some are even dying. And these are people that are not that far in age from me, or who I consider old, or who I consider, any more or less than risk in terms of risk stratification than myself. And I think it's very humbling, because it made me realize that, anything that any one of us does can be risky, and it gives you a certain appreciation for it when you do it. You just can't. You can't be my uncle used to love to use the word lackadaisical. You can't be lackadaisical. You have to be able to really approach every interaction in a very, very, in a way where you're really paying attention to what you're doing.
I think along those lines, it's been sort of a struggle for us, because we have had to sort of make the PPE recommendations. And we, in the beginning, we had very limited PPE, and we still, don't have great PPE. And so we're doing a lot of the reuse that Shanique was talking about, sort of reusing masks for multiple days, or certainly between patients. And then seeing our employees get sick and sort of keeping track of that, and, wondering, is that something that we did wrong? Did we make recommendations that were too lenient? The alternative being, if we run out, then nobody has PPE. And so trying to make those decisions sort of without logistics background, is a lot of pressure. So I think obviously scary that we're going to get it ourselves, and it's all around us, it's all around our colleagues, but certainly also feeling responsible for people around us too.
And just really quickly, I think an interesting thing on the other side is that, the hospital I'm in currently is a children's hospital. And going from here, you have primarily an adult hospital, mixed practice hospital, to 100% peds, where it's like a different world. The children are not being affected in the same way, at least right now, as the adults are. And watching just the vast difference in how these places are being affected and how these patient populations are being affected. It's truly amazing in terms of just thinking about biology and physiology at work. And yes, we have this multi-organ inflammatory disease process happening in the pediatric population. You're not seeing children affected in the same way, because that's the next generation. You know, but I find it very interesting when you think about the pediatric world and the adult world, how they differ in this pandemic.
Shanique, I think you were cutting out just a little bit there, but I think your question leads us to maybe tie in one from our audience. So we got this question. I'm wondering if those of you directly involved in patient care could describe how patients are presenting along the spectrum of severity and how your treatment has evolved over the past 3 months. And I think maybe even for Jeff and Amanda, thinking about how even you think about, you know, making sure that your facilities are equipped and how that has changed since the beginning of the COVID crisis and maybe to date?
Sure, maybe I can jump in first, talk about sort of the clinical presentation. So we've seen the full spectrum of disease. So we've seen people who are otherwise asymptomatic and test positive. We see people who feel a little short of breath but don't need extra oxygen and can go home and test positive. And then we've seen people who are really, really sick and are breathing really quickly and need oxygen. And some people even need, like Shanique is saying, need mechanical ventilation right from the emergency room. A lot of times we're seeing people who were tested positive, you know, a few days before we even see them. And so then they were at home doing okay, and then really sort of decompensating at home and coming in to see us requiring hospitalization. The thing that I have found really striking during this whole learning curve is that, you know, coronavirus is new, right? Like we did not know that we didn't know that it existed until, you know, we started hearing first reports from China, and we had no science to back us up. And I think that probably everybody here on this panel sort of prides themselves on making decisions with the best information that we can, right? We try to make evidence-based recommendations. We try to follow what we think is the right thing for our patients. And we were in this like very unknown. And so we were seeing all sorts of spectrum of things that we didn't really understand. We were seeing people who were prothrombotic, meaning that they were having blood clots. They were having, we were seeing people that were just having fevers over and over and over again that we didn't understand. And so I think that we saw sort of the whole gamut, and I started relying on what other people were doing. I was listening to my friends in Boston. I was listening to my friends in Atlanta. We were on Twitter seeing like how people in Italy were dealing with this. What airway interventions were they making? Should we be using these new drugs, you know, hydroxychloroquine, remdesivir, now dexamethasone as of yesterday. And so it's really been an amazing thing to watch the speed of science push forward, and how we have used that to sort of treat patients, you know, differently from a month and a half ago.
And I guess a little bit more specific on the presentation. So we've tried to set up like screening so we can separate sort of sick and not sick, or red and green. And I think in the beginning, we're following sort of the more classic, like cough, fever, shortness of breath. And obviously it is clearly not only that, you know, people have diarrhea or vomiting or nausea, nothing. And so I think it really is the whole entire spectrum, and, you know, our efforts to, in theory, keep people separate, maybe they're helping, but I think it's impossible because we know that so many of our green patients have come in and then tested positive. And so it's hard to say there's just one presentation.
I think that's super helpful. We actually just had a really interesting question. It's for Jeff and Amanda too. It says, you mentioned that some of your patients don't have electricity, and I would assume internet at home. Given this, how have you been able to adapt care to delivering healthcare in new, hopefully effective ways without relying on telemedicine or video conferencing?
So that is definitely a challenge for us because, I mean, we essentially, you know, on March 18th shut everything down. And so essentially didn't have clinic patients come in unless there were urgent visits, some sort of newborn or under 1 vaccinations. But trying to do telemedicine in a community that doesn't necessarily have digital or sort of smartphones or doesn't have strong enough internet access to do telemedicine is challenging. We do a lot of phone visits, and we're trying to increase that, but needless to say, our small rural hospital has not ramped up telemedicine as fast as other larger hospital systems have. We are still working on it. I think also in terms of electricity, one of the things is that some people come in and get admitted, are put on oxygen, and they just need a little bit of oxygen, otherwise they're stable and can go home. However, going home with oxygen if you don't have electricity is challenging. And so that sort of speaks a little bit to the step-down units that Jeff was talking about setting up. There were some created on Navajo Nation, but none of our patients actually met any of the criteria, because you have to be independent to go to these centers. So that sort of meant that some patients were in our hospital for a longer period of time because they didn't have electricity at home and couldn't go home with oxygen. So those are some of my initial thoughts, but it's definitely a challenge.
And maybe Jeff, I do think it's such an interesting question about access to telemedicine and lack thereof. I'm here in Chicago, we have a pretty big digital divide, so while many of us have been hearing about telemedicine and the rise of telemedicine and how it's taking over, there are so many kind of least among us, and particularly, I mean, it sounds like it's a rural urban issue. I'm curious, Jeff, if you guys have faced that in Philly from a public health response.
Yeah, thanks, Kristen. I think that's a great point, that even in cities like Philadelphia and I presume sort of Chicago, there is this divide that exists as well. I think that telemedicine has certainly evolved quickly during this time in all of our large health systems, and it has caused some challenges in terms of disparities in accessing care. And it's even sort of beyond thinking about access to healthcare, is how do we even just communicate with the public? People who may not have Wi-Fi, may not have smartphones, may not be easily reached in the same ways that we're now used to reaching. And so we've had to think through, from the health department side, what are the different strategies we have for engaging populations across the entire city who may not have the same access to information, or who may have different language needs and different literacy needs. And so we've been sort of working a lot with community partners. And I think if anything, my hope from all of this is that the partnerships that we've developed during this time will really endure beyond it. And so that once we do come out on this sort of hopefully soon post-COVID time, or whatever sort of the next wave, the next iteration looks like of our daily lives, is that those relationships will persevere so that we can continue to address sort of the ongoing health needs that Jared and Amanda have mentioned, and just really the importance of thinking through the impact that the social determinants of health truly do have on populations who lack access to healthcare.
Now we're talking about some of the vulnerabilities in our community. I wanted to switch gears a little bit. You know, we've had this national dialogue and protests around Black Lives Matter, and we know that it's inextricably linked to COVID-19 and the outcomes that we're seeing, right? That we see disproportionate impact on communities of color and on vulnerable communities. And I wonder if you and Shanique, being also pretty local to Philly, can comment on the movement in your communities and what impact it may have on the COVID pandemic.
So I would say that certainly Black Lives Matter and the protests in the wake of the George Floyd killing have catalyzed a lot of change in Philadelphia. And like you said, Shoshana, the intersection of the movement and the epidemic is really critical to address and to think of together. Our data from the health department have shown that racial and ethnic minorities had higher rates of infection and more severe infection than whites, a finding that has been shown repeatedly across the country and is a reflection of longstanding racial inequities in healthcare and healthcare access and the social determinants that Jared was talking about. And in Philadelphia, we've seen that neighborhoods with higher proportions of Black residents were really being hardest hit by the epidemic. And then we've had sort of these ongoing Black Lives Matter protests for the last several weeks, some culminating in several thousands of people. And as you'd imagine, these large gatherings of people do pose a risk to the spread of the coronavirus. But we're also entirely supportive of the movement and want people to be able to protest, but to do so safely. And so that has been certainly, I think, a challenge that's happening in our city and I think elsewhere around the country. Our department has been active in handing out hand sanitizers and masks at the protests, and then encouraging people who do participate that they then get tested. And we specifically say that they don't need to disclose that they were at a protest, only that they may have had an exposure. Fortunately, our ED data and our testing data don't show there has been an increase in cases since Memorial Day or the protests, but we are certainly keeping an eye on that and aware that that is certainly a possibility in populations that are particularly already vulnerable.
Mm-hmm. Shanique, did you want to add?
Yeah, so it's an interesting thing. So I am Caribbean, African American, right? I was born in Jamaica, but I've been in this country since I was a year and a half. And so the colliding of these two incredibly important things happening at the same time almost shows how we can't deal with more than one thing at any given time, right? Because no matter what, the Black Lives Matter movement has to happen. It needs to happen. There are inequalities represented beyond just, you know, people in one area or sector of the world. It happens in healthcare. Why are there such a disproportionate number of African-American male physicians? It happens in so many areas of this country. But yet, like Jeff said, if you're going to protest, it has to be done in a way that is as safe as you can possibly be, because we are still in a pandemic. And this pandemic, we don't know where the end of it will be. And so in a population that's already disproportionately affected by this virus, who are also the majority of the protesters in some areas, they're, you know, we're waiting every 2 weeks to see what's going to happen next. And in areas where you have some disproportionate inequalities with regards to access, this is a big deal. For, you know, it's known that African American women are some of the most poorly taken care of people in terms of the healthcare system. It is frightening to see what is happening, and yet it has to happen. And so, just like, you know, Jeff has said, those who protest need to do it safely, and this movement needs and has to happen. And as a person of color who has my own experience, I can't speak for anyone else's experience but my own. But all I do know is that between COVID, between me needing to intubate patients with COVID, between the Black Lives Matter, between me having young Black men but boys who are my children, and having to be woken up with nightmares about that in the midst of all this, we're going to have another population of people who are going to be dealing with these things. And it's once we get beyond the acute necessity to treat these critically ill people with COVID-19, you're going to have an issue of psych issues, depression, anxiety. How do people deal with being in uncomfortable situations where you feel at risk, whether because be due to your race or due to your profession? And this is a real thing that's going to be coming behind all this, that we need to, as a community, be aware of, because it's going to happen, right? These uncomfortable things are going to happen.
Amanda and Jared, you're working with a different underserved population in Navajo Nation. You've talked a little bit about the impact of COVID in light of its vulnerability. I wonder, do you have any sense of how Black Lives Matter might play a role in Navajo Nation, either directly or just in a broader sense in terms of ripple effects for those who are underserved in healthcare?
Yeah, I've been sort of thinking about this a little bit. I think like a lot of people, we've been watching very intently the news. We've been reading about what's been going on in the rest of the country. I think here in Tuba City, there haven't been protests. There's been, we've been on lockdown and curfew mandated by Navajo Nation, which has really limited perhaps people's, wish to support and feel the solidarity for what's happening in the rest of the country. So, I don't have a great reason other than that about why we are not seeing outward support of Black Lives Matter like other parts of the country. Although I will say that I think one of the things that is really striking here is that I think our community has been, it's small, and we've had an incredible number of cases. And so what Jeff and Shanique are saying is that protesting safely is so critically important. Here, every single person, not every single person, but an incredible number of people have direct contact and know somebody who's been affected by coronavirus. They've either gotten sick or their family members have died. And here, there are large family networks, there's large sort of extended family networks. And so I think that makes the calculation really challenging for people who want to support a movement, want to protest, want to gather, but feel this uncertainty about what that looks like in a place that has been devastated by the coronavirus. You know, I do think that there are obviously similarities among, you know, systemic and institutionalized disenfranchisement of people and populations that are both similar but also very different. And I think that I can speak for myself that I think that the population here probably does stand in solidarity, but doesn't have the same sort of protest that we are seeing in the rest of the country.
Does anyone, I was just going to say, we've got one question here that says, I hope you all are doing well emotionally, physically, and mentally. What are some ways you've managed the stress and uncertainty from the current pandemic? And I would say also the national outrage as well.
I guess for us, we do live in a very remote area, and there's a lot of beautiful landscape around us. So I think one of the benefits to being here is that we can go 10 minutes or an hour in any direction and be sort of in the middle of vast landscape and be able to socially distance and camp and be in the outdoors. That said, it is definitely all consuming. I mean, it's been all consuming since day one. I think the adrenaline has carried us through a lot of it. And I think we're sort of entering a new phase where that adrenaline is coming down a little bit, and there's sort of a, you know, obviously as much work to do and a lot of burnout. And I know there was sort of a question about furlough and things like that, and that's definitely a concern for people, given that, you know, small hospitals are not doing well financially. So there's definitely a lot of, you know, burden and stress still going on. But I think you know, in many ways our lives have been, I don't know, I guess not less affected, but we are still very busy, leaving the house every day, interacting with people we normally interact with. So like our day-to-day isn't that different, except for it's a lot busier and there's that added stress of getting sick. So I don't know if you have other things to add.
No, I think, you know, one of the reasons that we moved here to begin with is that we live, you know, within a few hours of many of the beautiful national parks here. And so I sort of, you know, am working an incredible amount, but you know, just being able to be outside with the family and exploring the region has really been rejuvenating, has been able to recharge. It allows me to recharge my batteries and get back into the clinical medicine, because I think burnout is real. I think that we are all feeling the stress of having to make really difficult decisions based on an uncertain, you know, situation.
I'm curious too. I just wanted to also note that this Zoom ends at exactly 60 minutes, so we can't go over. But I did want to maybe ask, maybe if you guys quickly can have a couple predictions about what the COVID-related. One specific question came from an audience member that Amanda alluded to about COVID-related furloughs and pay freezes on healthcare systems in the short term and the long term, and perhaps also if you guys want to muse about any other, I guess, big policy changes that might be happening, good or bad, during this current time.
I mean, so I think it's pretty, or not uncommon that many hospitals across the country have done pay decreases. And so, you know, that's happened here as well. I think there's risk of furlough in many places as well. I worry about this community and people being furloughed, because obviously it's not the easiest place to recruit to, and losing providers who want to be here will have a long-term impact. I think our hospital is slightly different in that we are a tribally run hospital. We're not technically IHS. And a lot of the IHS hospitals that are on the rest of the Navajo reservation have a different financial situation. And so that is tough for people here to see. But yeah, in terms of nationally, you know, obviously everyone always says that being a doctor is, you know, has a lot of job security. And obviously doctors are very much needed right now. And yet there is all this concern of pay cuts and layoffs that is stressful.
Curious if you have, oh, Shanique, go ahead.
I was going to say, I think this whole crisis has brought to mind that, I hope I'm not being a Debbie Downer, but being a doctor is not it's not always a very secure job, okay? So it kind of also depends on what structure you work in. If you work in academia, the furloughs or the pay decreases you might have seen in academic practice didn't happen in the same way that you did in a lot of the private practices. And in that same regard, some of the privately owned but well-endowed hospitals didn't necessarily have to make those changes. So what it brought to mind was how actually financially fragile the healthcare system is, even in places where you thought they were very stable. And, you know, I had about 3 or 4 days of furlough and decrease in pay, but I still was employed. But yet, that doesn't mean my colleague who was in a surgery center doing primarily elective cases was so lucky. And so, you know, the fact that physicians who always thought, or at least some of the physicians I know, have always thought, this is a pretty stable job, I'll always be able to feed my family. And then all of a sudden with this happening, they're not able to in the same way. Not to say that doctors are going, you know, hungry, but to see very huge changes in your pay overnight to some people no pay, like being furloughed, is a big deal regardless of who it hits. And I think not to say any person should, you know, it's not a pity party for anyone, but everyone is affected in a way that only they can really appreciate. But to me, looking at the medical profession as a pretty stable profession, yes, are we a little bit more stable than some of the restaurant workers right now? Of course, but it's not as stable as what we used to think of a physician as a physician 20, 30, 40, 50 years ago.
I would
Jeff,
just add.
oh, yeah, go ahead.
Oh, I would just add to that I think that you know, I would echo what Amanda and Shanique just sort of said are things that I've heard from my colleagues who work in the large health systems in Philadelphia, and then within the city and the Department of Public Health ourselves, we certainly are experiencing the same degree of pay freezes for sort of existing staff. But interestingly, because of all the funding that is now coming to address COVID, our department is one of the few in the city that is actually able to expand right now. So we are really trying to make available opportunities specifically around contact tracing. And so we're really building up a large COVID containment unit within the whole department to really address this, which doesn't address, I think, a lot of the challenges that my colleagues on the panel here have expressed, but it is a different aspect of this in terms of some of the funding and in terms of the jobs that exist right now, because that is going to be a big unit, and a big focus of our efforts moving forward is around containment and contact tracing.
I think one of our challenges here is that our small hospital is also our public health department. And so cuts to our medical staff are currently the people that are doing contact tracing. And so it's unclear what's going to happen, but we obviously certainly need to continue contact tracing, especially given there are still so many cases here on a daily basis. So yeah, no good answers, but it's a challenge.
Jeff, I'm just curious how your department has been working with, say, your local government and thinking about reopening.
Sure. So we have begun to reopen as of June 5th. We sort of entered the governor in Pennsylvania has sort of issued sort of a 3-tiered phase, a red phase, yellow phase, and a green phase for different stages for reopening, depending on the burden of illness by county. And Philadelphia, because we've had such a large burden compared to the rest of the state, we've sort of been the slowest to reopen. We've just begun to reopen in terms of some of the restaurants and what they're allowed to provide. And we are moving in the direction of reopening more things probably in a couple of weeks. I think it's been a bit of a challenge in terms of the relationship between the city and the state, just in terms of thinking about what do we feel comfortable reopening versus what do they want to see us reopen. You know, I think that we have tried to find compromise as best we can. And there have been some areas where we have felt that we still need to be a little more restrictive, much I think to the consternation of some folks in the community, but I think from our perspective of trying to still reduce the risk of spread, is something that we're going to continue to face on an ongoing basis. I think as more and more counties around us reopen, I think there will be increasing pressure for us to do so as well. So we're trying to really get ahead of that and acknowledge that at some point we are going to reopen more. How can we come up with the policies or the protocols to help support businesses, support restaurants, and support their patients or their clients and their customers?
We only have about 5 more minutes left, so I was hoping that maybe each of you could spend like literally 20 seconds providing some of the students on the phone or on the Zoom with any advice if you have to offer.
So maybe I'll start. So I think that the things that I learned at Bowdoin were strengthened by the Bowdoin community, the people that that were my friends and my classmates. Was incredibly powerful in the way that I started to see the world and think about what I wanted to do with my life. So I would say that, you know, it's about taking the classes, but what I think is so strong at a place like Bowdoin is this community of really smart people who are invested and may have different opinions than you and maybe think about problems very differently than you. I think that seeing the opportunities to learn from them, I think, was critically important for me. Sort of like Amanda, I was not a pre-med person, but I think that I was very prepared to become a pre-med person once I decided to do that because of the really, really, you know, talented people that I was surrounded by. It really helped, you know, made me think about what I wanted to do with the world.
Yeah, and I'll just echo that. I think the network is very strong. I think sort of calling on alumni. We actually have a Bowdoin senior here for the summer who is interning with us. So it's, you know, there's a lot of people doing interesting things and related things that I think can call on, but also your professors and people, yeah, classmates. So I think that's the community. And I know it's hard if it's online for the spring, and who knows what will happen next year, but yes, still sort of connect with those people.
I think this is going to sound a little cheesy, but I think whenever you think about what you want to do in the future, you have to do what you love. And it's going to take a while to sometimes figure that out. Like, you know, medicine's a huge field, but when I am working and doing and taking care of a child or taking care of an adult who I think that my skill set can help, it gives me a very, very selfish personal gratification. Which means when things get hard, I know that I'm doing what I love. And, you know, whether there's a change in the money, change in the PPE, it doesn't matter. I know I'm doing what I have trained so long for, and I love it. Because when things change, you have to know that you're doing it for all of the right reasons. And if that's for self-gratification, well, what's wrong with that, you know?
So I think I would offer and just sort of just say that what Shanique mentioned earlier, just around the common good and how that brings so many people together at Bowdoin, and knowing that and sort of thinking where everyone who's at Bowdoin right now, you know, where your careers will lead you. You're going to be addressing. You may have an interest in addressing some hard social challenge, and I think that for me, when I reflect back on my Bowdoin education. And the advice that I would offer is something that Amanda mentioned earlier on, of just, I dabbled in so many different classes, and just to be exposed to them, because I think that richness made me a more well-rounded physician, but I also think that it helped me think through a problem from different angles. And again, sort of no matter whether you pursue medicine or not, if you're going to tackle a hard social challenge, it's valuable to be able to think about it from different angles. And that, I think, is one of the real strengths that a liberal arts education can provide, and really sort of exploring all the different classes and fields that are out there.
I think that's a perfect place to end, because I think we're going to end quite quickly. I just wanted to thank you guys all for sharing that. I think Jeff just probably stole my closing remarks that said, never have I seen a better show of the common good here. So I think I heard compassion and ingenuity and real true honesty and bravery from all of you. So I want to say thank you. And then to the class of 2004, we have a toast in a different Zoom room that will follow this. It will be less formal. So I hope you guys will all join. And I wanted to thank, I think there are about 4 decades of polar bears that have joined us, at least those that registered. So I wanted to thank you all for making your time. And again, and also wanted to thank Linda and Amy from the college for helping to make this session possible. And thank you guys all for all you do.
Just also want to shout out, our class of 2004 has about 25 or more physicians. So while we are so proud to have these 4 featured here, we recognize a lot of you are doing really wonderful work on the front lines and you know, in the ripple effect of COVID-19. So thank you, and all the polar bears who are doing this work, for your service. And I think we will say good night. Thank you.
Thank you all.
Thank you.